cancer, one of the leading causes of death, is there an herb that will work for nearly every type of cancer?
One of the reasons that I use curcumin for patients is it has multiple anti-cancer targets. So that it's a single agent that gives multi-targeted anti-cancer action.
Cancer is a disease that is typically treated with very expensive medications. I mean, typically tens, if not hundreds of thousands of dollars in many, many cases.
What the evidence actually shows for the effect of natural product extracts on various relevant molecular targets in various cancers, we see that there's actually quite a large amount of evidence that supports using various molecules, natural products, and pharmaceuticals that are already approved and have been around for a long time to affect anti-cancer activity along that pathway at that target. So that's called molecularly targeted anti-cancer treatment. So I think that the most important movement that needs to occur is for the patients to recognize their own value in the decision-making process and demand that they have access to these therapeutic choices because they're available, they're supported in the evidence base, and they have the right to ask for them rather than whatever the physician is otherwise offering in the conventional realm.
This is Dr. Mercola helping you take control of your health. And we are joined today by Dr. William LaValley, who really focuses most of his clinical work on the treatment of cancer and is going to shed his wisdom on this area. So welcome and thank you for joining us today.
Thank you, Joe. It's great to be here.
So we first met a number of years ago, 7, 8 years ago, somewhere around there.
Yes.
And a conference in your hometown in Austin, Texas, I believe. And it was the first and only time I've been to Austin. And was really excited to meet you. It was really not related to health, but we got together and really had a great time. And I learned that we share a lot of similar philosophical approaches, but one of your main passions is the treatment of cancer. And like me, you were trained in general medicine, but really took time off and devoted significant amount of time to understanding the biochemical pathways so that you could support people nutritionally. And I found that fascinating. I've actually referred a number of close family members and friends who come down with cancers to your practice. And I'm wondering if you could describe your journey in that area so people could know what better understand your perspective.
Sure. I went to medical school began in 1980, and in 1982 I was on an exchange program to the People's Republic of China. That was back in the old days before China was open to the West, and it was a fascinating experience for me, and I was there to look at traditional Chinese medicine and acupuncture. I was specifically interested at that time in the brain chemistry of acupuncture. And I saw treatments and things being administered to patients in a way that did not make sense to me. And one of the important messages that I learned there was that natural products, natural molecules from plants, from animals, that are already available in nature have been used by the Chinese for at least hundreds, probably thousands of years. And that deeply changed my perspective in the world, in medicine. So I came back to medical school and thereafter looking how I could integrate the perspective of conventional pharmaceutical administration as well as natural extracts, natural product supplements is what we call them in the U.S., administration. And so I've been practicing that since 1986 and realized in the mid-2000s that my knowledge base was really far behind, that I never learned the science of molecular biology, the way that molecules traffic information and signaling information to each other in these molecular maps of biological activity. Because in the 1980s, when I was in medical school in Houston at Baylor College of Medicine, there were no specific classes in the medical curriculum, the basic science curriculum, because molecular biology was still pretty much in the laboratories. And that realization in 2005 reoriented my time in that I took about a 75% sabbatical time to learn molecular biology, specifically the molecular biology of cancer. I didn't realize at the time, naively so, I didn't realize how vast the subject was, and it was probably a good thing because I may not have started at that time.
And how long did you devote to that learning journey?
The best that we can calculate, I think, is somewhere between 9,000 and 9,500 hours building a database, a relational database from the PubMed literature about the molecular biology of cancer. And one of the important lessons I learned is that the molecular biology understanding can be applied across the range of diseases and symptoms that are characterized in the scientific literature. And so that knowledge is applicable by going into the database, PubMed, and the related databases, and looking at the molecular pathways that are relevant in those particular diseases.
And maybe, so as I mentioned at the introduction, that there appears to be an herb that seems to be universally useful for just about every type of cancer, which is really odd because cancer is consists of a wide variety of different molecular pathologies, and one wouldn't necessarily suspect that there'd be one herb that would work for most of them. So maybe you can describe your discovery of that process.
Sure. When I went back to the literature and looked, how can I support the decision-making process and the recommendations that I'm making for treatment from the scientific literature, including literature that goes from the treatment of humans with oral products like pharmaceuticals or natural products, and this is where I learned about this molecule called curcumin, all the way down to its use in animals and then its use in the test tubes or petri dish. And that molecule comes from the traditional spice from the root plant called turmeric. And that turmeric contains curcumin and related curcuminoids that carry the yellow-orange pigment that is used as a dye originally in many years past, as well as it's what gives the food curry and wherever you use turmeric, the yellow-orange color. And turns out that scientists have, I think, I know actually that there are some that are in the U.S. who come from, their families originally came from India, where this spice had been used for many health reasons, and they began to look into the scientific validity of this and began testing this molecule, curcumin, against a variety of diseases in the petri dishes or the test tubes, as well as in animals, and now it's emerging into studies in humans. One of the amazing things about curcumin, and it actually, I think the word amazing gets used too often, and I think it really does apply here, is that this molecule has some profound anti-inflammatory activity and has activity in many molecular targets. So there's molecules that are in the cells, and those molecules interact with each other along certain pathways or tracks. The traffic of that interaction, the signals that are transferred in that trafficking of information in the molecules, presents many different targets or molecular specific complexes. And in many targets, curcumin has, whether it's causing an increase in traffic or increase of the activity of that molecular target, or a decrease, an inhibition of that activity in that molecular target, again and again we see that the result is an anti-cancer result. And one of the reasons that I use curcumin for patients is it has multiple anti-cancer targets, so that it's a single agent that gives multi-targeted anti-cancer action.
Okay, and you had mentioned that curcumin is really an extract of the plant turmeric, and to get the molecular actions that you're seeking in your cancer patients, it would be nice if they could just take the whole herb, but unfortunately, while there's some curcumin in there, there's not enough to make a significant difference. So can you describe the process of how you need to take large amounts of this and what types of concentrations you had and some of the early work you did, because there were no concentrated forms available, and you had to basically teach people how to make these extracts.
That's right. Well, the turmeric root contains about 3% curcumin concentration, and one of the biggest limitations of curcumin as a therapeutic agent is that it is very poorly absorbed in the raw form. It's lipophilic. It loves oil or fat, and it dissolves in oil or fat. And the absorption that a person would get by taking 100 milligrams of turmeric is the 3% curcumin and only 1% of that, because curcumin in its raw form is only 1% bioavailable or 1% absorbed. The natural product industry has developed a standard of a 95% concentration of curcumin. So when you see natural product supplements available in the industry, we see that there's commonly capsules that have 95% concentration. And initially, years ago, that was what we had available for patients. And even that, taking a 95% concentration and taking it orally in a capsule, a dry powder in the capsule, only 1% of that could be absorbed. And so in order to get amounts of curcumin in the bloodstream that are reasonable to have therapeutic effect, so to have therapeutic concentrations in the serum, people had to take large amounts of curcumin. There was a study done where people were given 8 grams of raw curcumin powder per day for 2 months without adverse effect, without harm, and still only were able to demonstrate minimal or only moderate amounts of curcumin in the serum. So in searching the literature, I found that a way to change that, to dramatically increase the bioavailability, the amount of curcumin that can be absorbed, is actually a very simple process of bringing water to a boil and then putting those capsules or some dry powder in it from use it by the teaspoon and boil it for 10 to 12 minutes. And that increased the amount of curcumin that was now dissolved in water from that 1% amount up to 12% or so. And that amount is a vast number of curcumin molecules that is now in a bioavailable or absorbable form. And I had patients do that for years. In fact, I still do have patients do that in addition to taking curcumin that has been prepared in a more bioavailable format as well.
Yeah, and can you provide us with some examples of patients you treated that responded favorably to curcumin, and maybe a few to demonstrate the wide range of patients who might benefit from this?
Sure. I use the administration of curcumin as a cornerstone for anti-cancer protocols across a broad spectrum of diagnosis, different types of cancer. And the challenge in identifying the value of any one particular molecule is that that treatment plan would have to be administered using just that molecule compared to another cohort, another group of subjects that were using a similar trial without that molecule. And my protocols generally use multiple agents, so I'm using multiple natural products as well as multiple pharmaceutical prescriptions.
And these are typically targeted for the specific individual. So you don't have some shotgun protocol used for anyone with cancer.
That's right. So we look at the pathology reports. Sometimes we were able to get molecular profiling done or genomic profiling done, and based on the results there that can show molecular targeting as an option, then we focus on whenever we have that data. And so there's a truly broad array of disease that curcumin has significant potential for benefit. The challenge is, how are you going to get enough into the bloodstream to make a difference? And that's where the bioavailability of the product, there's now a range of those products on the market that allow substantial amounts of curcumin and some of the metabolites of curcumin that are therapeutic. And I think people now have much better options than had been available 5 years ago and certainly 10 years ago.
Well, that's terrific. And can you give us an update as to the progress that's been made? Because we first started discussing curcumin 5 or 6 years ago, maybe longer. And I know you were concerned that the natural products industry really hadn't provided a supplement form of curcumin that had high bioavailability that could eliminate the essentially self-processing that your patients required, because what I don't think you mentioned was that it's not as simple as boiling the water and putting curcumin in it. It volatilizes and it tends to discolor your entire kitchen. This deep yellow pigment is really difficult to get out. So it's doable, but at a great inconvenience.
That's right. That I have told all the patients that I've treated with recommending the what I call curcumin in water, that they have a side effect called yellow kitchen syndrome, and it gets a lot of giggles initially, and then they realize after they're doing it for a while that curcumin as a pigment coming off the steam that is now volatilizing the molecules that are now a pigment in the kitchen. And some people have gotten that yellow pigment essentially around the kitchen, and then as well as on their clothes, and it's a big issue. So
and it's used as a dye. I mean, it actually dyes clothing, so it's a permanent coloring agent.
That's right. And so convenience as well as efficiency, I think, is driving some of the changes in the forms of curcumin. And because it's a fat-loving or lipophilic molecule, a lot of the preparations that have now been developed to make it more bioavailable include some sort of oil or fatty acid involved in the matrix or the preparation, so that the molecule will be more easily absorbed and more readily available for that absorption once it's taken into the GI tract. So I'm talking, all of these are oral products, and we're not talking about any injectables. There's development in the pharmaceutical industry for analogs, different types of related molecules that will be on the market that are going to be, I think, also powerful molecules in years to come. I think a lot of that is fairly far away, and right now we're looking at a lot of products that are available that have more bioavailability, more absorbability, and that usually is about somewhere between 7 to 8 times higher absorption than the raw, unprocessed 95% concentration dry powder. One of the challenges is maintaining a therapeutic amount of curcumin in the bloodstream, and so I'm very interested, and I now recommend products for people that give a sustained release, so that not only is the product bioavailable, increases the absorbability or bioavailability through making it more absorbable by using an oil or fatty acid, and then making it so that it has a long amount of absorption, rather than a rapid peak of absorption and then a decline of the amount in the bloodstream. So a lot of products that do have increased bioavailability will cause a larger amount of curcumin to go into the bloodstream in a much more pulse-like fashion. So a patient will take the capsule that has the increased bioavailability fat-soluble complex that's absorbed, and get a higher amount of curcumin in their serum, in their bloodstream, and then that amount drops, and because it's not a sustained release. And so when I'm making treatment recommendations, I want to provide recommendations that include a high sustained amount of curcumin in the bloodstream. And the way to do that is to provide a curcumin product that is that is associated with a increased bioavailability matrix. So that's usually some sort of a fatty acid or an oil that it is mixed up and dissolved with, and then in some form of a matrix that allows it to be released over time, so that the patient's getting sustained released increased levels in their serum of the curcumin. And that sustained release permits a longer therapeutic impact rather than just a pulse of high amounts of serum curcumin that then decreases because the product is released all at once rather than sustained over time. So I think therapeutically it's of greater value to have a highly bioavailable, sustained release curcumin product for its therapeutic value.
Perfect. And perhaps you can review your process for treating patients with cancer, and what actually maybe even discuss how you came about shifting your clinical practice to that mode. I mean, you shared that you went to China and had this perspective that there was a radical difference.
Right.
But how did you shift into, because you could use that perspective to treat a lot of different illnesses, but why did you settle on cancer? And this is a particularly intriguing question because cancer is a disease that is typically treated with very expensive medications. I mean, typically tens, if not hundreds of thousands of dollars in many, many cases. That typically, many times is covered by insurance, but if not, typically exhaust the patient's life savings in an effort to rescue them. So as a result of that reality, there is a strong incentive to protect that revenue stream from, and as a result, then many of the medical boards are pushed to prosecute clinicians who use treatments for cancer that are outside of the normal paradigm or conventional standards. And it is typically one of the riskier areas to treat because many physicians wind up losing their licenses. So I'm wondering, with that reality, and you knew that going in, why you chose to treat cancer.
That's a really good question. Back in the beginning of my practice in the late 1980s and early 90s, I saw patients who had a diagnosis of cancer, and I really had very little understanding about how to provide any benefit. And I looked into the natural medicine community, and there were a lot of treatment recommendations that were fairly prevalent in the natural medicine, or at the time it was called holistic medicine or alternative medicine. It's now evolved to, I think, a more appropriate name of integrative and complementary medicine. That's how we have it in Nova Scotia. And what I realized is that a lot of the natural medicine recommendations at that time in the 90s were based on folklore, or were based on a lot of clinical empirical evidence, experience, and observation, but really had very small amounts of scientific evidence to say that here's what we're using to target this particular molecular activity in that cancer. And I wanted to get better therapeutic outcomes, and it turned out that in the 90s then there were a number of patients that, even though I was using treatments that I did not understand the molecular basis of, a large number of these patients then were improved, and some of them achieved remission, and I didn't predict who it would be. I couldn't have known. I was quite surprised to see some people that I thought would do very poorly did very well, and I thought were going to do very well did not do so well. So at that time, I learned the lesson of no longer internally making judgments or predictions and leaving the possibility of people getting better open to them. And they got more and more improvement across the patient population. And then there were a number of physicians who became interested in the kinds of treatments that these patients were getting. And so I decided that I wanted to be able to provide a scientific basis for that. And that's how I got involved in going into the literature and learning molecular biology. I think if we look back in the medical education of the U.S. and Canada, which are fairly similar, that because molecular biology was not widely taught in the 1980s, it started to become taught in the 90s. I use an arbitrary cutoff point. It's purely my own arbitrary designation that the turn of the century, the physicians who graduated and are licensed and practicing prior to the turn of the century have likely significantly less exposure to learning about molecular biology than are the much younger and more recent graduates. And that, I felt, put me at a disadvantage in making treatment recommendations. So in learning the molecular pathways and learning molecular biology of cancer pathways and learning that what the evidence actually shows for the effect of natural product extracts on various relevant molecular targets in various cancers, we see that there's actually quite a large amount of evidence that supports using various molecules, natural products, and pharmaceuticals that are already approved and have been around for a long time to affect anti-cancer activity along that pathway at that target. So that's called molecularly targeted anti-cancer treatment, and it's widely practiced in oncology today. What's not widely practiced is the use of the natural products for the molecularly targeted anti-cancer activity. And so I provide that for my patients because the evidence base suggests and supports the use of these treatment recommendations. I tell patients very clearly, and it is absolutely true, that these treatment protocols are not a cure for their cancer. I wish they were. That they're intended to slow the progression of the cancer and to provide multi-targeted, multi-agents, so multiple therapeutic agents, anti-cancer protocols that are in addition to and not instead of what they have already chosen to take with their conventional oncology team. And when I saw that more physicians were interested in this information, they needed to know, so show me the evidence. If we're all agreeing to do evidence-based care, and I think it's pretty clear that there's a broad consensus of medical practice in the U.S. and Canada that we're all agreeing to provide evidence-based care, then it gets to the question of what constitutes sufficient evidence. And that's where I think a lot of the issues of the debate occur, in that some folks, some physicians say, the only evidence that I'm going to accept for treatment recommendation is the evidence that comes along with the approval of a particular pharmaceutical agent and the usage that is on the package insert or the label for that particular product. And so we see that is called the on-label indication or on-label usage for that particular pharmaceutical. And we see that when those drugs are approved, there's a lot of evidence now for the drugs that are approved currently for pharmaceutical anti-cancer activity, that they have a particular type of cancer that it is approved for usage in. What has happened is that oncology physicians have also used those same approved molecules for a cancer that it was approved for use on the label. They all frequently use that same pharmaceutical drug for treatment of a different cancer. So for a drug, for a treatment that has not been approved for on the label. And evidence, I think it was in 2012, is a very interesting article that came out about how approximately 30% of conventional oncology treatments are for treating cancers with drugs that uses the drugs in a manner that is not what they were approved for. So for an indication, a usage that is not on the label, that's called an off-label usage. And 30% of these chemotherapy drugs were used in a non-approved way or an off-label usage. And that's a perfectly legitimate, perfectly legal usage of a drug. Once a drug is approved in the U.S. and Canada, a physician is able to prescribe and administer a drug in a manner other than what it was originally approved for, and that's off-label usage constitutes about 10% of the pharmaceutical prescriptions in primary care, and in oncology, 30%. So this is a very broad usage that occurs, and by definition, there's not then that controlled trial that supports the evidence. That provides the evidence that supports the use of a new approved usage for that drug by the FDA or by Health Canada. And the way that I provide these natural product recommendations or the off-label pharmaceutical prescriptions for patients in an anti-cancer manner is to do so based on information that shows where these particular molecules affect these relevant targets in cancer cells, which I think is the lowest grade or lowest type of data, or in cancer cells in animals, and that's a more relevant data, and frequently it's in mice or rats and rodents, and then also for usage of these molecules in humans, and in particular if it's an oral administration. So that's a very high criteria of evidence. And I use that spectrum of evidence to support the recommendations. Today I did a quick search on the PubMed database and looked at how many articles or references does PubMed show for curcumin and anticancer. And over 500 articles or 500 references came up. And when I did the same search for curcumin and cancer, it was over 2,300. That doesn't constitute a specific recommendation that curcumin can be used, but when you go down into that literature, then and learn about the molecular pathways, that evidence now starts to be sufficient to say, well, what's the benefit risk? And I tell the patients that we're using these products with the intention of anti-cancer activity, and we're trying to have multiple anti-cancer activities on multiple molecular pathways, on multiple molecular targets. And one of the visualizations that I use for patients to understand this is a street map. If you're looking from above onto a street map, and if it was on the computer in 3D, that would show you a traffic on a street map in a big city. There are some areas, some roads that are really large that have lots of traffic, and other areas, other roads that branch off that have less traffic, and some roads have very little traffic. And I'm looking where the data shows that these are high traffic signal pathways, and where can we use molecules to alter that traffic from a pro-cancer set of pathways or a pro-cancer effect to interfere with that pro-cancer activity and drive anti-cancer traffic. And people start to understand that there are multiple pathways, and that when you use molecules like curcumin has a very broad range of anti-cancer targets, and I show some of the literature that supports all that information, and then they look at, well, what's my risk versus what's my potential benefit, and that's how we decide to administer that. In the case of curcumin, administer that, and we go through the same thing with other items.
Well, how about if you can provide some general recommendations for people with cancer, the sort of a shotgun ones that work for all. Like we said, curcumin probably is beneficial to add to the regimen of just about any type of cancer because it works on universal pathways that seem to lower that. Now, from my perspective, improving your diet would be a useful thing. And if a person has insulin or leptin resistance, and you could actually measure your fasting insulin or leptin levels to determine that, but most likely you'll have clinical signs, which would mean you're overweight, you have high blood pressure, high cholesterol, diabetes. If any of these, metabolic syndrome, if any of these clinical conditions are occurring, most likely insulin leptin resistance are a factor. And if that's occurring, because there are patients with cancer who do not have insulin resistance, so that's a different ballgame.
Right.
But my guess is most do, and since you treat cancer patients a lot, is that your experience? Most have insulin resistance?
Right.
In the early stages.
Absolutely. Metabolic syndrome is frequently associated with it in a broad range of patients as well.
I just wanted to confirm. Yeah, so I just wanted to confirm that. So if they have this insulin or leptin resistance, then it would seem from my perspective, if I was counseling someone, that they should go on a ketogenic diet, a nutritional ketogenic diet, to resolve that. And that would be in combination with some intermittent fasting to really kickstart the system to resolve that insulin leptin resistance and get the body fat percentage down. And then once that's resolved, then you can fine tune it based on a person's needs. It's not something that they need to be on forever, but at least to resolve that resistance, because that seems to be one of the most profoundly driving factors in most patients. And that's my view, and I'm just wondering if you can comment on that.
Yes, I agree with you that a ketogenic diet is really appropriate in many cases, probably the significant majority of cases. And one of the ways that I demonstrate that to patients, because as you know, a ketogenic diet is, for most people, a pretty significant alteration in the way that they're eating, that I ask them to obtain a PET scan, PET, a PET scan. And that PET scan is a type of imagery that uses a decoy sugar or a sugar analog like glucose. It's actually, you can think of it as a first cousin to regular glucose that is administered as the contrast agent by IV or orally, or could be both. And where that sugar concentrates is where we're going to see an increased density of light in that imagery. And it turns out that it's been known for, gracious, probably 80 years or longer that solid tumors and some of the blood cancers, in particular, solid tumors are sugar-loving, sugar-avid. Another term is they are addicted to sugar. And I use that PET scan to demonstrate to patients that here is objective proof that the tumors that you have in your body in these locations are sugar-avid, and they're taking up sugar at a rate much higher than the regular other healthy cells. And I want to drive home that message so that they are motivated to alter their diet to have a low carb intake, and that they're then causing their body to generate additional nutrient supply molecules called ketones. That is the basis of the word ketogenic for a ketogenic diet. And what that means is that we're trying to provide an anti-cancer antagonistic pressure on the cancer cells by reducing the amount of sugar that's readily available for absorption, for uptake and absorption and nutrient usage in the cancer cells, by reducing the easily available sugar in the diet and compensating for the nutrient reduction in sugar by increasing healthy fats and oils.
Yeah.
So a ketogenic diet
and that's an important point, because many people kind of are attracted to paleo because they think that's a nutritional ketosis, and though that can do it, doesn't do it as well, and it does it in a way that may be counterproductive because it's relatively high in protein. So you have to be really careful, because many of these amino acids, like I think glutamine, leucine, can actually stimulate carbohydrate production and then secondarily insulin production. So, and then also, if you can comment on this, is that, well, before I go into that, when you said really eliminate the carbs, that's really all starchy carbs. So it's pretty much unlimited green leafy vegetables, so because you can't overeat those. But with respect to the protein, is it, from your perspective, because you've looked at studied these biochemical pathways, do you feel that in addition to the extra protein being used to stimulate carbohydrate production, is also a factor to stimulate the mTOR pathways, which are useful for building muscles, but when you're treating cancers, not necessarily good, because mTOR is a pathway that increases cellular proliferation?
Right. There's a lot of work in the cancer research for how to manage or how to modulate the mTOR complex, the mTOR target. And one of the products that's out there that's been approved as a pharmaceutical for usage for decades is the pharmaceutical drug Metformin. And that has an anti-cancer activity in inhibiting mTOR. Turns out curcumin has a similar effect.
On the mTOR pathway?
On the mTOR, on the upstream to mTOR AKT,
wow.
And
did not know that.
Of that PI3K. So what the value that I've extracted from this database is looking at the pathways independent of the way that most of us get our continuing medical education, which is targeting particular pathways based on what pharmaceutical is supporting that continuing medical education, or what natural product supplement is supporting that continuing medical education. And what I'm looking at is how do we get a broad range of these molecules in place so we get multiple target activity. And the sorry, I got sidetracked. Go back to the ketogenic diet. Importantly, in that I call it the low carb diet, is that you're absolutely right. You're not going to eliminate all carbohydrates. You're not going to eliminate all sugars. There are sugars and carbohydrates in vegetables. Technically, there's sugar in animal products. Meats do have some form of sugar, and even if you could have a zero sugar diet, which I think is almost impossible, that your body's still going to generate sugar through the process of gluconeogenesis, so sugar new making from the liver. So we're not trying to have a no sugar diet. What we're trying to do is to have a minimal amount of blood sugar and to use the dietary options to drive the development and distribution of the ketones throughout the body from the food supply, and maintain a moderate amount of ketones in the blood that thereby affects the cancer cells in an adverse and antagonistic way, because they have less available of their desired nutrient fuel of sugar. And managing that dietary recommendation can be challenging for people because they want to know, well, how much fat should I eat? How much good, clean, healthy oils or good, clean, healthy animal products should I eat? And what I tell them is monitor your ketones by using the urine ketone sticks. In fact, I prefer my patients to be on the multi-sticks that they can use that test their urine 2 or 3 times a day. Just put the bottle of multi-sticks in the bathroom and check 2 or 3 times a day how much ketone level is showing in the urine. And if you're having a moderate amount of ketones, then you're maintaining a good ketogenic diet. Even having a small amount of ketones is a good ketogenic diet. And that gives people a much better marker rather than trying to count the amount of fat calories or protein calories or carb calories or maintain the appropriate ratios to continue ketosis. This gives them
there still may be some value to count your protein calories, because it's really easy to overeat protein. And in my experience, most people are eating 200, 300, 400% more protein than they need.
Sure, absolutely.
So at least to look at that, and there's some really good free apps that you can get online, or an application for your smartphone or your tablet, which is MyFitnessPal, one of the best.
Yes.
And you can easily enter, I mean, they've got databases with just about every known food known to man, and you can enter it in there, and it will tell you how many grams of protein and carbohydrates. So you could, it's a little bit of a challenge to do it initially, but once you've got it done after a few days, it's pretty much repetitive. So you can figure it out pretty easily. But, the formula I recommend is from Dr. Rosedale, and that was 1 gram per kilogram of lean body mass, which is about a half a gram per pound of lean body mass. And most people, it would be especially people with cancer, they're going to run 20, 30, 40% body fat. So if they weigh 300 pounds, they may be 150 pound lean body mass.
Right.
And that's only 70, even though they're 300 pounds, they only need like 70 grams of protein. And, you have a big piece of steak and you're over the top at one meal.
Sure.
So
absolutely.
I just think that's, I don't treat cancer, and that's why I'm really excited to hear your feedback, because I don't treat anyone actually at this point, but you're in the trenches and you're seeing this, and you're seeing results with this approach, which is, I find very reaffirming, because certainly from a theoretical perspective it makes sense, but you had the opportunity to try it out in the field.
One of the biggest challenges I think that patients who are diagnosed with cancer have is that there still exists within a lot of the oncology, conventional oncology community, the what I think is denial that sugar, glucose, is from the diet can be fueling the growth and spread, the proliferation of their cancer cells and the cancer in their body. And I've had patients come to me saying that their oncologists have said to them, it doesn't matter what you eat, go ahead, or you're losing weight, so increase your calories.
No. They're losing. Let's give you some Ensure.
Yeah.
High fructose corn
Yeah.
syrup and terrible omega-6 fat.
Yeah.
It's a prescription to accelerate cancer growth. I mean, that is so classic.
It is.
They should that product should be banned from the marketplace. It has killed so many people, and all the so-called experts are just clueless on this.
It's pouring lighter fluid or gasoline
Yes.
on the fire. And so I tell them to avoid that, and I give them the understanding about why and how it is, and that's where the PET scan is very helpful for demonstrating to them that their cancer is sugar avid, that is addicted to sugar. And interestingly, what happens is it brings in sugar. The cancer cells that are sugar addicted or sugar avid usually bring in the glucose at a rate up to 10 times higher than healthy cells. And rather than using that sugar for creating energy for the cells, it does that a little bit, a small amount of energy, but it uses those bits and pieces of sugar that it breaks down to create that small amount of energy, rather than feeding it to the powerhouse of the cells called mitochondria that create a large amount of energy. They use those bits and pieces of sugars for building blocks of other molecules that the cancer cells need to make in order to grow and spread. So it's using those sugar as building blocks, and that unfortunately has not been widely understood by many patients. I think that it has been understood by a larger number of oncologists recently, and that there is coming out that recommendation to minimize or at least lower the sugar. And as you know, the recommendations from SafeRead is to have ketogenic diet treating cancer as a metabolic disease. And the way that I approach is, yes, as a metabolic disease, and as the other constituents in the microscopic environment around the cancer cells, in a manner to not only antagonize the cancer cells, but reduce the support that the cancer cells have in the microscopic environment right around them. And that's really important, because a lot of the current therapies do not have targeted microenvironment treatment. And with the anti-inflammatory value of curcumin, curcumin has anti-cancer activity not only in the cancer cells, but outside in the immune system cells that can either be anti-cancer, or there are some immune cells, unfortunately, that become what I describe as kidnapped or co-opted, programmed by the cancer to support the cancer and suppress the anti-cancer immune system. And so the curcumin can have anti-cancer activity on cells that are outside of the cancer cells that are otherwise supporting the cancer cells. So it's a very versatile molecule.
Terrific. Now, as we're recording this interview, there's been a real milestone in technology announcement. About 10 years ago, the cost to sequence the human genome was probably about $50 to $70 million. But as we're recording this, there was a company that had launched a product that actually they sold, but you had to buy $10 million worth of these machines, but it would essentially sequence the entire human genome for under $1,000, which is a major milestone. So, and interestingly, if you graph that out, the slope, and I'm sure many people have heard of this, is the Moore's law, that things tend to accelerate every 2 years or 18 months or even every year. But this is accelerating like 200 to 300% faster than Moore's law. This drop in the technology implications on genetic sequencing. So and you've been doing this for a while, so I'm wondering if you've noticed that, if it's affected your ability to get more information at a lower cost, because many of these tests are not covered by insurance.
Yes, well, it has profound effect when we can get the data. So generally, when I'm making a treatment protocol, developing a protocol of recommendations for particular patients' cancer pathology results, those pathology results are generally describing the cell type, so the specific diagnosis of the cancer, and rarely are those results including information about the molecular pathways that are overactive or underactive in those particular cancer cells. And so I'm having to, like the other physicians who are developing treatment recommendations, including the oncologists, to make best guesses about how to treat that cancer. And you can look at the current chemotherapy protocols for particular cells, particular diagnoses of particular types of cancer cells, and there are a range of these chemotherapy protocols that can be administered, and without doing the testing to evaluate whether that particular chemotherapy kills those cancer cells. In other words, is that group of cancer cells sensitive to that type of chemotherapy or not, we're making our best guess. There are now available laboratory evaluations of living cancer cells. So when they take out a surgical specimen, bits of it can be sent to laboratories that will test the sensitivity of those cancer cells to various chemotherapy agents and to other agents, including other pharmaceuticals, and importantly, some of the natural health supplements. In addition to that, what you were talking about is the genomic testing, and as well, I'll speak about some of the molecular profiling that is done on the specimens after they have been taken to the pathology lab and after they have been stained and put onto slides, where the genetic activity that is characteristic of those particular cells is evaluated, or what is also called proteomics, or the protein expressions of the various molecular targets is also evaluated. Whenever we can get that data, and it is becoming increasingly more available through laboratories in the U.S. and now in Canada, then those results will tell me in particular that, for instance, as you mentioned, that the target mTOR was hyperactivated, or that inhibiting mTOR or inhibiting other molecular targets is an anti-cancer intervention in that person's cancer, and another person could have the same diagnosis with the same cell type and run through the same type of genomic testing or proteomic testing and not have that molecular target be obvious in the results. And so targeting that particular target would not be appropriate or valuable in that case. So wherever we can get better data about sensitivity, chemosensitivity, or sensitivity to other anti-cancer agents, as well as, very importantly, the genomic testing and the proteomic testing, we want to do that. It's not generally covered by the insurance companies at this point. I think that it will become much more so, and that's because when you have a more targeted result, you can see where you can focus the treatment. So I think that will make treatments not only more effective and ultimately more cost effective as well. And so when I make these treatment protocols, we're looking in general, making best guesses about what targets are generally available or generally expressed in that type of cancer. And then if we're fortunate enough to have some of these very specific results for that particular patient, then we can really focus treatment, and then they can get a better therapeutic result, because we're not having to cover other targets that are not so relevant.
Terrific. Well, we're kind of running out of time at this point, so what I wanted to conclude with is a description or information if people wanted to contact you to consult for any health challenges they have, including cancers. And what I neglected to mention at the introduction is that I believe you are dual licensed. You're licensed to practice medicine in the U.S. and in Canada. And you spend a significant amount of time up in Canada, which is why you referenced the Canadian system quite a bit in the interview. So maybe if you can provide your contact information, so people if wanted more to consult with you, that how they would connect.
Sure. There's two ways that I help people in that regard. Is my medical clinic is a small clinic in Nova Scotia. It's where I have a medical office, and I see patients there. And people from the U.S. come up either through Chicago or through Newark, and it's quick access through the city of Halifax. And my office is in Chester in Nova Scotia, is where I see patients. My phone number there is 902-275-4555. And when I'm in Austin in the U.S. is where I'm doing the research for these protocols, as well as I also do consultations for other physicians, where those physicians have patients who have a particular diagnosis. So, for instance, a patient with pancreatic cancer, and the physician wants to implement one of the protocols that I provide, then I will do a consultation with that physician's patient and then make recommendations to that physician for implementation. And that way patients are able to get it locally without having to travel to Nova Scotia. I don't have a clinic for treating patients in Austin because it would just be too much to have two clinics in such a far location currently. I'm looking to that.
Not too many legal battles or challenges with the medical boards.
Well, there's always the requirement for all of us to maintain clinical evidence-based treatment, and so I find the biggest issue is with other physicians, not with patients, is with other physicians who are not yet educated about the evidence base, and so they make rash recommendations or attacks or ridicule, and that's just the way that is. I think that there's much more openness to the recognition that there's a vast amount of data out there showing that there's value for targeting multiple pathways, whether it's in cancer or autoimmune disease or neurodegenerative disease.
I couldn't agree more. So, well, I want to thank you for all you do. You've given your contact information, and I did one last question. Was have you were in the process at last time we spoke about compiling some training materials for professionals that incorporated this molecular database that you created. So, is that available yet, or is that a resource?
Yeah, we're developing that now. We have to make sure that when I have a large number of articles and I'm looking at them, then I have to make sure that we're maintaining copyright. So I have to my database, when I go in, I look at the articles, but I can't upload that as a single database. So we have to essentially prune and clear the database so that it just shows the copyright appropriate abstracts of those articles and shows the links for those articles. I am available to talk with other physicians, and as well as the patients of those physicians sometimes come take the protocols and then bring them to their physicians. It's a challenge right now because there's so much information that's not readily known by so many physicians that they become afraid. I think one of the biggest issues certainly in the U.S. and Canada is that when a physician wants to administer one of these natural products or several of them, as well as some of the off-label pharmaceuticals for their anti-cancer usage, that they are afraid of recriminations or disciplinary actions, and that's I think very unfortunate, because the evidence base does exist for it, and it's consistent with the way that other types of conventional medicine are practiced using off-label pharmaceuticals as well. So I think that the most important movement that needs to occur is for the patients to recognize their own value in the decision-making process and demand that they have access to these therapeutic choices, because they're available, they're supported in the evidence base, and they have the right to ask for them rather than whatever the physician is otherwise offering in the conventional realm.
Thanks so much for watching. Remember, hit the like and subscribe button so you can get more videos that can help you and your family take control of your health.